Yeah. Sheesh. Watch us how we move like this. Watch us how we move. Oh, yeah. Watch us how we move like this. Watch us how we move. Oh, yeah. Watch us how we move like this. Watch us how we move. Oh, yeah. Watch us how we move like this. Watch us how we move. Oh, yeah. We gon' move like this, like this, like this. Yeah, we gon' move like this, like this. Oh, yeah. We gon' move like this, like this, like this. Yeah, we gon' move like this, like this. Oh, yeah. Watch us how we move like this. Watch us how we move. Oh, yeah. Watch us how we move like this. Watch us how we move. Oh, yeah. Watch us how we move like this. Watch us how we move. Oh, yeah. Watch us how we move like this. Watch us how we move. Oh, yeah. We gon' move like this, like this, like this. Yeah, we gon' move like this.
Hello. Good evening, everyone. Good evening, distinguished colleagues, partners, stakeholders, and everyone joining us from across Nigeria and beyond. My name is Victor Ekpo, and it is my pleasure to welcome you to another edition of the NCCP Thursday Live. The NCCP is actually the Nigerian National Cancer Control Plan, and this particular one is for the 2026 to 2030, and it's an ambitious initiative of the Federal Ministry of Health and Social Welfare designed to significantly reduce the burden of cancer in Nigeria by 2030. The plan provides a comprehensive roadmap that prioritizes cancer prevention, early detection, timely diagnosis, treatment, palliative care, research, workforce development, and robust cancer data systems to drive evidence-based policies and decision-making. So more importantly, it's important that we understand that this is just a national commitment to ensure that every Nigerian has access to quality cancer care, regardless of where they live. And that's the crux of the discussion for today. However, a plan is only as effective as its implementation. And we are going to be talking to early stage investigators, right? And this is where early stage investigators come in. Early stage investigators, which we'll call ESIs, the people we'll be hearing from today. ESIs are the operational engine of the National Cancer Control Plan. They are the hands and feet of implementation, working behind the scenes to translate strategic objectives into measurable action. And they coordinate activities across the various technical working groups and plan program delivery units, PDUs. So we'll be listening to different ESIs that are supporting different TWGs and PDUs. Their work is to make sure that research is ongoing. They are to develop policy briefs, to analyze data, to monitor progress, to ensure that the NCCP is alive, is responsive, is accountable, and more importantly, that it's impactful. So today's important conversations, I have here with me 3 ESIs from different TWGs and PDUs. And it's very exciting because these are the people that actually do the implementation of the amazing plans that we've all spoken about across the different weeks. So it's my pleasure to introduce our distinguished panelists. And I would like to go into introducing each of the three panelists. We have here with us Dr. Opeyemi Bolajoko. Dr. Opeyemi Bolajoko, can you please say hi? It's good to have you with us, ma. You're muted, so.
Hi, good day, everyone.
Good day. It's a pleasure to have you. It's evening in Nigeria, but you're good.
The day. It's still the day.
Yeah. So we also have with us Dr. Omoremime Elizabeth Dania. She's a lecturer at the Department of Biochemistry, Covenant University, Ota. Dr. Dania.
Good evening, everyone. I'm happy to be here. Thanks for joining us.
It's a pleasure to have you. It's amazing to have you. We also have Dr. Oluloye Blessing, who is a psycho-oncologist. She's a lecturer also at the University of Ibadan, Nigeria. Dr. Blessing.
Hello, everyone. Good evening. Thank you.
Good evening. Okay, fantastic. So just before we get started, I'll try to read a short bio of our first presenter, Dr. Opeyemi Bolajoko. I'm sure that there's a better way to pronounce this word. It should be Bolajoko. Am I right?
Yes.
Bolajoko. Dr. Bolajoko is an early career investigator of the Inclusive Cancer Care Research Equity, ICCare Consortium, and a research associate in the Cancer Health Equity Research Program at the Mayo Clinic Comprehensive Cancer Center, Jacksonville, Florida. Her expertise is in community engagement, research, and cancer survivorship. Her work is contributing to the development of home care cancer survivorship plans for cancer survivors and their family caregivers to improve patient-reported outcomes. Through culturally tailored solutions, she's applying precision public health approaches to improve community responsiveness to cancer risk reduction and survivorship. She has a TWG that she's ESI for, but she's also the ESI of all ESIs. So I would like Dr. Bolajoko to tell us what her experience has been and then to make her presentation.
Thank you, Victor. I'm very excited to be here to share what we have been doing in our units. I currently work with the ESIs of each committee, and I also work as the ESI working with the treatment care coordination and patient navigation subcommittee. And today I'm just going to briefly talk about what we do. I'm going to just talk about the two, about what I do. Can the slide be up? Yes. So right now, we have an amazing program delivery unit, and the program delivery unit is comprised of ESIs working with every subcommittee and regional groups that are implementing the National Cancer Control Plan. One of the things we do and we prioritize is coordination of all the activities within our group. For me, I'm in the treatment care coordination and patient navigation subcommittee. So my job is to ensure that our leaders, our co-chairs, our members have access to all the documents, ensure that we hold our meeting, and ensure that every action in the committee is carried out. And So we provide systems and network. We ensure that all the infrastructures that are necessary for each of the subcommittee is available, and even when they are not available, we definitely know how to improvise. And our goal is to ensure effectiveness of each of those subcommittee, ensure that whatever everything we're doing is data driven, because we also keep an eye out for real time data, and that's from each of those committee. So we are very, very conscious about our data. We are tracking our data. We are developing dashboard. Those of although that we that's there, that's where we are going. But most importantly, we are really looking at we are orchestrating multiple sectorial stakeholder and synchronizing the subcommittee activities. That is what we do in our own PDU. That's as a PDU, that is ESI, and that's because we have ESI in all the other units. Next slide. And also, when you look at what we do, so we provide logistical support. We have, I mean, this is how we work. We just have, like, I would say, three pillars. One is governance and accountability. We ensure that all our committees are well coordinated. We ensure that we ensure that we strengthen governance, and we ensure that everyone, for example, every member of our committees are accountable. That is because we make sure that all action plans of every subcommittee is carried out. These are not done by me. These are done by my colleagues in their subcommittee. And also we ensure data driven. We ensure that data driven and visibility, and then effectiveness and impact. That is what we are going to be doing, because our own role is to ensure the effective implementation of the National Cancer Control Plan. Next slide. I earlier told you that I also work with the Treatment Care Coordination and Patient Navigation Subcommittee. In our subcommittee, our own focus is to, I would say that our focus is on treatment and patient coordination. So the first thing we did in my subcommittee as the ESI, I made sure that I kept an eye out for what my co-chair wanted us to do. He wanted us to map the resources we currently have. And interestingly, we already do have a lot of reports and documents from other committees in the past. We do have NICRAT, there's already a report, and then we also have outstanding investigators and clinicians who are members of our team. So we're able to look at that. They were able to help us map where the resources are, what are the gaps. So this is for my committee. And one of the things we have done is to know where all the resources are. So where we are going is to ensure that we kind of create a directory. We're going to be working with all the other especially the groups in the regional groups, and working with all our ASI to make sure that every cancer center or every institution providing services are captured in our directory, where clinician can come, patients can come, and quickly have a quick scan of, this is where I live, where is the nearest cancer center to me? And not only that, which ones will I be able to afford? So we're not just going to be talking about the availability of these services, but also would have, we'll kind of give patient and clinician heads up about some of the, how cost effective it might be. So this is what we're doing. Next slide, please. So as my role, I'm wearing two hats, and I'm very excited to be working in these subgroups, working with the PDU and also working as with the treatment coordination group. It's so exciting. In my mind, my point is to ensure that everything is convenient. I know cancer care may not necessarily be convenient, but at least it's easier. It will be easier than what we currently have. And that is why, for me, my goal is to ensure that we integrate. In my mind, I'm just thinking about the patient. How does the patient get from point A to point B? How does the patient, okay, now that you receive the diagnosis, how do you proceed? And that is why it's so exciting working with the other early stage investigator in other subcommittee. So it gives me an idea. I have an idea of what's going on in some other subcommittees. So, and we're leveraging the strength and the possibilities that the other subcommittee brings to the table to ensure that we have effective coordination. We're not there yet, but that is actually where we're going. Thank you.
Very interesting presentation. And so in all of this, the one question that we are going to try to answer really is, what can we do today to reduce cancer incidence and deaths in Nigeria tomorrow? That is the one question that we are all trying to answer.
Yeah.
And I understand that the NCCP is bringing everybody together to answer this particular one question, because everybody can work in silos, but if we work together, we are able to get greater outcomes. So from your experience and from your committee and from
Yeah.
your support to the
From our
TW,
committee,
yeah,
I believe that if we can create a convenience space, like from what we're doing in our committee is to make sure that service is available and accessible. I mean, we're not creating the service because we believe that there's services. So, but we want clinicians and patients to know the services that are available. So, more or less like care coordination and patient navigation. So that is what we want to do. We want to do that effectively. And for me, I believe that that would really, really help. It will, because timely access to tests, care, survivorship programs, SDOH program can really make a difference. I mean, it can make a huge difference from progression, even, because if a patient does not receive timely access, that can make the patient progress from stage 2 to stage 3 and from stage 3 to stage 4. So that's, if we can ensure to reduce the delays in access to care, that would definitely reduce morbidity and mortality. So I know that if we accomplish all our goals, even if it's 60% of our goals, it will be very, very significant. The impact will be huge on the current statistics.
interesting. So it's your committee handling the SDOH, right?
No. We handle treatment, care coordination, and patient navigation.
Okay. The SDOH has been a huge
Yeah.
deal in the country the last 2 months, and they've been great launches across the country.
So
And
my committee now will work tirelessly to make sure we're navigating patients, especially those that needs the SDOH services and resources, to make sure they get it, and then also not only to get the SDOH resources, but to also to give them timely information that they need to access the care that they really need, and services like, there's a lot of treatment, and not just treatment, even tests and continuous assessment and quality improvement programs that they need to access for survivorship.
yeah, very important work that you're doing, Dr. Bola Joko. And I would like to thank you for the amazing volunteering services that you're doing so far for the country. I'd like to bring in Dr. Denia, who is an early stage investigator for the Workforce Development Subcommittee. Before I bring her in, let me just read what her short bio is. So she's a lecturer at the Department of Biochemistry at Covenant University, Otta. Her research lies at the intersection of cancer biology and natural products discovery. She focuses on the mechanisms of oncogenics and plant-based therapeutics. Now that I'm saying plant-based therapeutics, it sounds like herbal medicine. Designed to reduce cancer health disparities in Black population. So alongside our research, Dr. Dania is actively engaged in cancer prevention and community advocacy initiatives. So I'd like to bring her up and ask her what the work has been so far for TWG that she's supporting, and how it has been. What are the unique opportunities and challenges that you faced? And then you can make your presentation. Thank you.
Okay. Thank you very much, Mr. Victor. So yes, as he said, I work with the I'm assigned to the Workforce Development Subcommittee, and I'm working with a very wonderful team. And though I'm supposed to be working there, I'm learning a lot. So the team has it's a family. It's just NCCP has given me a family where I'm able to interact and learn. Though I'm supposed to help in kind of like facilitating the implementation of our plans, but I myself have actually learned a lot from our chair, the co-chair, and every member of the team. So actually, for the Workforce Development Subcommittee, our focus mainly is capacity development. So our interest, the focus of the team is to develop Nigeria cancer and workforce. So yes, I believe from the data available, we know that our health care system requires more hands. So I believe more can be done. And part of our priority is basically to help to develop capacity. So to do that, we started by trying to understand the baseline. What do we have currently in the country and what needs to be worked on? So as a team, first, a survey tool was developed by the team led by our co-chair, and that survey tool is already ready. We are just waiting for approval to launch, to disseminate it. And the reason for the survey to basically is to understand, to have a complete understanding of the data of Nigeria workforce, and also the cancer workforce generally, and also to be able to have a database of our diaspora experts. So at the end of the dissemination of this survey, we should be able to at least be able to lean on some of our diaspora. We have most of them on the NCCP already, but we believe with this survey tool, we'll be able to have real data that we'll be able to work with. So we're going to be having data-driven strategy to be able to increase the data cancer workforce capacity in the country going forward. Then also, so far, what we've been working on, so what I've been assisting in the subcommittee to work on is also to plan the upcoming ESI training. So the focus of the team also is to train the ESI. So we have ESIs, as Mr. Victor has explained earlier, we have ESIs in all the subcommittees and in the geopolitical zone. So the plan also, what we are working on now is developing, the work plan is actually ready. So it's just to kind of like how to put some finishing touches in the total plan so that we'll be able to have with ESIs trained, so that we'll have the conversion of our participation to become more productive in our implementation. We've got most of us actually, this is the first time we are embarking on such a big project, helping the nation in trying to fight cancer. So with the ESI, so our subcommittee, the workforce subcommittee is also working on developing the capacity of the ESIs. So also in the some months coming, we also plan to develop the capacity of, not really develop, yes, develop the capacity of the MDT. So we want to work on building the MDTs. Oh, sorry, MDT is multidisciplinary team. So we are trying to build the capacity such that we'll be able to improve clinical coordination in the country generally. And so far from our work as a team, we've been able to, as I said earlier, finalize the workforce survey instruments, and we are just trying to put finishing touches to start the workshop for the ESIs. And going forward, basically, the whole plan is to be able to ensure that at least by towards the end of this year, there will be tangible improvement in the workforce, in the cancer workforce in Nigeria, so as to be able to increase the outcome for cancer patients. So not apart from increasing the outcome for the cancer patients, our interest also is to be able to try to enlighten the primary at the PHC and at the PHCs, the community health workers, though that's like a plan in the pipeline, to be able to enlighten them so that we'll be able to detect cancer faster and reduce morbidity from cancer. We all know that when cancer is detected earlier, it's better, it's treatable. the outcomes are usually better than when it's discovered in the later stage. So basically, as a team in the workforce development subcommittee, I have had to work with senior persons in different fields, and I've actually been learning a lot from them. So all I do, most of what I do basically is to help to coordinate things, reach out to um persons. So okay, sorry, we reach out to persons. We've also had to collaborate with the research and innovation committee, and since our focus is on developing the workforce, we also want to spotlight what outstanding researchers, clinicians have been doing so far. So we had the first one last month, and we've been able to spotlight one of our clinician already who is working, and her team who currently have a clinical trial ongoing. So that's actually also part of what we do in the workforce development subcommittee. So we also intend to spotlight researchers, our clinicians, and institutions that are involved in research, treatment, and everything involved in cancer, such that while people are making the sacrifice to try to reduce the incidence of cancer and um, help patients to have a better outcome, their work is also being brought out so that others will be able to understand know what we are doing. So the work will not be done in silo, and this will help collaboration. So I think so far that's what the team has been doing for the past few months since we started work.
Awesome, awesome, awesome. Thank you so much, Dr. Dania. Interesting work. And workforce is one of the most interesting parts of the NCCP. You have a workhorse as your chair for the for the Workforce Development Committee. So I can imagine that they are tasking you a lot over there. But one of the challenges that people talk about a lot when it comes to workforce development is either all the workforce is in the big cities, or uh, or there's just a Japa syndrome that we can't even find people to do the work in a lot of places. What's been your experience so far, based on what you're doing?
Okay, so as you said, yes, the issue of the Japa syndrome is also part of what we are considering. As my chair has said, Dr. Lashebikon is really a fighter. She's always interested in seeing things work out. So part of what we'll be working. So far, we've not sent out the survey yet, but from what we know, as what you said is actually true. Most of the specialists are in the cities, and that's why part of the plan of the subcommittee is to try to train, um, diversify, like try to train the workforce, even the workforce, the community health workers at the primary health care center, so that they will also be able to assist. Though we've not rolled out the plan, we've not actually prepared the work plan for that. So it's like our work is assigned in phases. So our first phase is training the ESIs, then the next one is the MDT, and finally we'll reach the community health workers.
Okay, interesting. So I'm going to ask you the same question that I asked Dr. Bola Joko. What is the one thing that we can do today? In fact, what happened was, I think working in a cancer center is quite difficult because you have a lot of, what I say, good stories and bad stories, and then good days and bad days. And then something happened, I think yesterday. And then what popped up on my mind was, what can we do today to reduce incidence and mortality among cancer patients in Nigeria? So, summarize everything that you said. What can we do today through workforce, right? That will
Yeah.
reduce cancer incidence and deaths in Nigeria tomorrow.
Okay, so I think for reduction in incidence, we will have to, we'll I would say awareness, increase awareness, and somehow this SDOH actually helps, will go a long way, because part of the reason why people do not show up early, even though they have the symptoms, is because everybody's aware of the cost of cancer treatment. So people would rather want to stay back and try to manage it in one way or the other. But if they are aware that, okay, even if all they have to do is try to look for the treatment, and they will be having some kind of support. I believe people will show up earlier, and it will be able to get treatment earlier, and will end up be able to reduce mortality in the long run. But for incidents, I think yes, awareness. Basically, we have some modifiable risk factors that we could work on, like lifestyle changes, more activities, increased activities, eating healthier. So we could actually work with our communication team to increase awareness in that aspect, so that we'll be able to have people wo- kind of like work on the modifiable risk factors so as to reduce the incidence of cancer. Then for those that end up observing such symptoms, they'll be able to show up earlier if they know that they'll be able to get some form of assistance while they are going through treatment.
Interesting. Thank you so much, Dr. Dania. I'm going to really bring in Dr. Blessing Oluloyo. Dr. Blessing, let me focus on the English name. I'm sure I'll learn how to pronounce it, because now, based on what you've said, if we succeed in all the things that you've done, then we are now going to have more survivors. If we have more survivors, we now have to start thinking about survivorship, life after cancer treatment. And Dr. Blessing is a member of the Survivorship and Palliative Care Subcommittee. And she's the ESI supporting that committee. And I'll just read out her short bio, because she's also a psycho-oncologist with expertise in psychological care of people affected by cancer. She's a lecturer at the University of Ibadan, where she teaches and researches psycho-oncology education and clinical practice. Her focus is basically on the psychosocial aspects of cancer. So we are talking about psychological distress, anxiety, depression, suicidal ideation, stigma, which is a very big thing, quality of life, survivorship, and the development of culturally relevant interventions for cancer patients and their caregivers across Nigeria. So I would like Dr. Blessing to now weigh in on all the things and share experience with what the work has been so far in the Survivorship and Palliative Care Subcommittee. What has been done to answer this one question: what can we do today to ensure that we reduce cancer incidence and deaths in Nigeria? Dr. Blessing.
Okay, thank you very much. Yeah, thank you very much. I am Blessing Olunloyo. Thank you very much, Mr. Victor. And good evening, Nigeria. I am the early stage investigator for the Survivorship and Palliative Care Subcommittee, and we are saddled with the responsibility of establishment of evidence-based and implementation framework for survivorship, psycho-oncology, caregiver support, and palliative care within the National Cancer Control Plan. And for us to be able to achieve this goal, we are not going to do it alone. And I must also say it emphatically that the group has actually been, the subcommittee has been a family too. At my own end, is a place where I've been learning. And by God's grace, I've been working closely with the chair, Professor Choma Asuzu. I've been working with the co-chair, Professor Bra Vivas. And then we have amazing people. We have Professor Okoye, and so many of them on the group. And they have really, really been helpful in the implementation of what we have to do. Then actually what we are doing presently, we started reviewing existing documents, because for us to bring out a framework, we should know what is on ground, we should know the gaps, and then we'll be able to kickstart. And also, we have also been trying to get baseline assessments. We have been trying to get baseline assessments from the clinician's perspective, the caregivers, the patient perspective. We have also been working on the psycho-oncology tools and guidance, all to ensure that our patients have quality care and they are given holistic care. For us to be able to do this, we are working together. We'll be liaising and working together with other subcommittees. We have a lot of them here, because we'll be working with patients. And for us to be able to deliver this, we cannot do this in isolation. And then those who are going to benefit from this, the patient first. Because the reason why we are here, the reason why there's NCCP Technical Working Group, because of the patient, because we are looking for a way where There will be holistic care. We're looking for a way where they will be treated with dignity, not taking their dignity out of it. And then the caregivers and relatives. Yeah, this is something about we on the survivorship subcommittee. We are not just looking at the cancer patients, we're looking at their caregivers too. Because before we see our patients in the clinic, some people actually among them. Whenever we are in the clinic, we used to say something that we're only seeing the patient. This patient is somebody's father, somebody's mother, somebody's daughter, somebody's uncle, somebody's aunt, somebody's just related somehow. So we are not taking away the caregivers. We also into the framework we are doing at our own end. Then the oncology care providers, yes, we are working, they are going to benefit from what we are doing by subcommittee. The federal and state mental ministries of health, the society, everybody will be able to benefit from what we are doing. And then what do we want to deliver? We want to deliver the survivorship care plan. We want to deliver a psycho-oncology, social support, psychosocial support works. These are the things we want to work on, and we have actually started working on them. And all of this came out from the fact that we noticed a whole lot of things which it's actually regular. Like everybody could see it in the country, could see it that there's limited psychosocial rendered to cancer patients and their caregivers. This has been a whole lot, and people have been talking about it. And then fortunately, here we are in 2026 to 2030 care plan, where we are trying to understand that this should also be brought in to make the care holistic, to make it holistic. Then besides that, we are also trying to make a national survivorship framework that will be implemented, that will be used across the country, and this will be culturally relevant. There'll be culturally relevant ones, not the ones that we just see outside there, the ones that is going to manage our people here in Nigeria. So that is what we have been working on, and the subcommittee has really, really been amazing. They have been rubbing minds together, and as the there, we have been ensuring that scheduling meetings, during our meetings, kept, they are well recorded, and then using that to actually progress in our work. Thank you very much, sir.
Committees to the patients themselves. You are dealing with patients that are already diagnosed. So we are not talking about prevention. We are talking about patients that are already diagnosed. And this is interesting work that you are doing. And you've mentioned a lot of things, including the fact that it has to be culturally relevant. And which is why I'll now have to go back to the question again, right? Because now I have to say, the question says that, what can we do today to reduce cancer incidence and deaths in Nigeria tomorrow? And because you said culturally relevant, you are talking about in Nigeria in particular, but also not just in Nigeria, but in different regions of Nigeria, because the different regions of Nigeria have their own cultural differences, right? So what are we doing? What can we do? If you were asked to pick one thing that we can do, what would that be that we can do to ensure? Are you with me? Dr. Blessing, can you confirm that you are still with us? Oh, our screen is frozen. Okay. So if you can put up I would like to just show us what the different PDUs and TWGs of the NCCP is doing. So we need to go back to the very first slide that we shared. And to show what the different subcommittees are for the Nigerian National Cancer Control Plan. So we are looking at about 10 different committees, subcommittees that have the ESIs in each of them supporting them. And we've spoken to people from 3 of them, but I'll just read out what these 10 committees are. So we have the Prevention and Early Detection Committee. We have the Diagnosis and Pathology Systems. We have Treatment, Care Coordination, and Patient Navigation, which Dr. Bola Joko spoke on. We have Survivorship and Palliative Care, where Dr. Blessing is. We have Workforce Development, where Dr. Denia is. We have Research and Innovation, Cancer Data, AI, and Digital Health, Community Outreach and Engagement, Partnership, Resource Mobilization and Financing, Monitoring, Evaluation, and Learning. So I'll bring everybody back up on the screen, and then we'll talk about how we can put everything all together. They say that one of the jobs of the ESIs is to ensure that there is collaboration across different TWGs, right? So it's what can we do to make sure that this collaboration happens. So I'll speak with Dr. Denia first. How important is community ownership and stakeholder engagement in the implementation of the cancer control region, on cancer control plans, rather? Yeah.
Okay. Thank you very much,
Community
Mr.
ownership
Victor.
and stakeholder engagement.
Okay, thank you very much, Mr. Victor. So, in as much as we're trying to improve the workforce, so I believe for it to be effective, the community also have to buy into the plan, because for if we are bringing in an idea into the community or trying to enlighten them about some of the factors that cause cancer and some of the things that could be done to reduce the incidence of cancer and encouraging early detection and the rest. Without the support of the community, it would not work. So the community, we have every plan, um, every plan to try to reduce the incidence of cancer or the outcome has to be bought by the community. And we understand in this part of our world, we understand the importance of our community leaders. So I believe for this plan to be effective, we'll have to collaborate with them. So bring our ideas to them, listen to them. Sometimes we come with a plan that we want to implement. They will explain to us the best way it will be able to be implemented in their community. And if we're able to work closely with them, then the outcome will be better. So because the whole plan, the whole agenda is to try to see how everyone in Nigeria will be able to buy into the NCCP plan of trying to reduce the incidence of cancer and mortality by 2030. And we just making the plans and talking will not work if the community do not buy into our plan. And sometimes, so basically what I'm trying to say is we have to collaborate with the community so as to be able to find the best way to implement the plans that we have for them, or they will also be able to tell us, okay, so this is a priority for their community. Like every community is not the same. Even the based on our geopolitical zones, for example, the level of environmental pollution or the pollutants in the environment will be different based on the region. So if we're able to meet with the community directly and get their input, then I believe our work and our plan will be more effective.
Awesome. Awesome. Thank you so much. Dr. Blessing, welcome back. Dr. Bola Joko, are
Thank
you
you.
on? So Dr.
Okay, I
Bola
don't know
Joko
if
is
I
one of
can
them.
respond to my
Yes, I
question.
am.
Okay.
Yes,
Okay.
Dr. Blessing, go ahead, please.
Yes, please. Dr. Blessing, please go ahead.
Thank you very much. Thank you, Dr. Balajoko. Thank you, Dr. Victor. Yeah, actually, sorry, I tripped off. Okay, so I actually wanted to make like an explanation concerning survivorship because on our own side, maybe as psycho-oncologist, when we call somebody a cancer survivor, I think just like Mr. Victor said, somebody that have been diagnosed. But from I'm trying to cancer today, something like that, if I could still remember. So from the prevention stage, now this is the screening stage. And one thing that we have to deal with is fear. Most times when you even take free screening to the environment, to the community, and then you tell people to come out for screening, not everybody comes out willingly. Even when somebody is feeling signs and symptoms in the clinic, and then you told the person, okay, we have to run some screenings, and then somehow they are seeing something like mammogram, they are seeing pap smear, then there's a fear that comes in. And most of the patients in our own facility, some of them, they come early. You can assume they come actually early. But they were told to do 1 or 2 tests and all of that, and then they feel, because of fear, they're afraid. They're afraid it's cancer. They're afraid it's this, is that, and then they just leave the facility. So one thing we can do today first is to look for a way to deal with fear. And not just awareness. We have learned some evidence-based research, and then we discovered that people actually have the knowledge of cancer, but what is their attitude towards practice? They have the knowledge, but it's the practice. See somebody across the road and ask the person, have you had your self-breast examination this month? And then they look at you as if, are you saying I'm going to have cancer? So if we can actually start from that end, then people will gradually, so even if there will be early symptoms, gradually, then they present in the hospital on time. Because the best for every oncology care provider is having a patient that comes in early. Because at this stage, the prognosis will be good. Everybody is happy to work because there will be high survivorship. But when people are not coming early, or maybe they started and then you told them maybe after the first visitation, okay, they have to do CT scan, they have to do this, they have to do that. I'm not taking away the financial aspect. Financial toxicity is real. It is real. But when we take away things like fear, and that is where we come in as psycho-oncologists majorly. And then what we do is that in my facility, we ensure that when patients come in for the first time, we make use of the distress thermometer to scale and rate their psychosocial distress as at entry. What's the anxiety symptoms? What are the depressive symptoms? Is there any form of fear? And then we try to debunk, because this fear sometimes comes from false beliefs. We try to debunk them. We explain to them. We have seen patients that don't want to take chemo because they felt that chemo is infused through the brain. So the reason why cancer patients does not really have their air, they don't understand that it's a side effect of some of the drugs that have been taken. They felt you have to scrape their air so that you can infuse through their skull. These are the things that are happening in our community, and then it prevents our people from coming on time. So when we are able to do that, people present on time, we start treatment on time. Every treatment leads to high survivorship. Now, the other part that we work with, the palliative care, that is another thing. When patients start treatment, and then they are being told that, okay, there may be palliative care management. You see patients and caregivers developing cold feet, because it's as if they assume that you just certify the patient as dead. So all these things are things we have to understand, and these are the things we are working on in our subcommittee to ensure that these are well established. Psycho-oncology is well established, palliative care management is well established, and we have a unified national survivorship framework. Thank you very much, Sas and Ma.
Thank you, Blessing. Spoke very passionately, and I can feel you from here how intense it can be, especially when you have a patient that should have come early and you're happy for the patient initially, only for the patient to disappear and come back when the patient is really, really bad. It makes the work very difficult for everyone. So Dr. Bola Joko, you are one of the most excited people to be on NCCP that I know. And I like to ask why you are so optimistic. This is not the first Nigerian NCCP that has ever happened, and so why are you so optimistic that this one is the most? This is going to be the most impactful one. This one is going to just blow everybody away, and that we are going to make the kind of impact that we want. So that will be one of our last questions for today. So
Thank
tell us
you so
about.
much. Thank you so much, Victor. I'm truly very excited about the NCCP because for me, I see opportunity to make a difference. I know that we've had, a, a lot of our senior colleagues have started the work. To be honest, it's not a new work that we're doing. It's because some people started something in the past. And that is why we can even stand up today and say we want to implement. So I don't believe that it didn't work before is because it's the stage. So this time we're not just coming up with a report, we're working on whatever has been reported, we're working on implementation. And I'm very excited because of the excitement that other colleagues, senior colleagues, my colleagues bring into the work. I mean, we see people working, they're not being paid, but they are excited to be part of it. This is voluntary work, and it's the excitement is there that we're going to make a difference. And one other thing about this is the fact that it is centered on patients. So you could see that from the outgo. It's not about clinician, it's not about the government, it's not about investigators, it's not about research. It's about implementation. It's about putting the patient first. So, like when you hear Dr. Dedino and the other senior members of the NCCP team talk, you can see how much time and energy they are putting in. They're not just putting in time, they're putting in money, their own money. So this is, I believe that this is different from where, in the past where you're looking, okay, so he's funding it. So how much is the federal government bringing? And so you see that now the patient are actually at the center. Every subcommittee has patient advocates and we are accountable. So there's a form of accountability. And for me, I see a lot of opportunity to make impact, to move the needle, to do something for my country, and to do something for the population. Sometimes we say my country as an abstract, but behind every statistics, it's actually people, family, people's father, people's children. I lost my aunt to cancer. I lost a very sweet neighbor to cancer. And so to just know that we're going to be able to do something. It may not be I wouldn't by now we cannot. I know in the years to come, we'll be able to measure the impact of what we're currently doing now. So I keep my excitement and optimism. I see opportunity to help. And I know that a lot of people also have seen this opportunity to help. And that's why we do what we do.
Thank you so much. Thank you so much. It's been an amazing discussion with the three of you, Dr. Bola Joko, Dr. Daniel, Dr. Blessing. Interesting conversations, and we are very optimistic with, just like Dr. Bola Joko is, that this is going to really, really push the needle, to just at least something for cancer patients across Nigeria and across Africa to be excited about. I remember that we had a conversation, right? And she's saying that if Nigeria gets it right, Africa is just going to get it right. And
Yes. Yeah,
it's
and
been
I'm very excited, and you're going to see why I'm excited. Dr. Dedino will be joining the conversation shortly, and there's just a way. We don't just do research, we don't just do our job. We also have fun. To be honest, so because Dr. Dedino is coming to announce an amazing program during the forthcoming NCCP in-person meeting. A lot has been done and everybody have been working virtually, but we're going to have this one that all the members are coming from all over. So, it's going to be an in-person meeting in Abuja, and it's I don't want to let the cat out yet, you know.
Okay.
But let me just say, it's not a dance. Just imagine, we're talking about cancer, we're talking about dance. That is Dr. Dedino for you. We have fun. We have fun walking. So Dr. Dedino will be, is going to join us. She's already at the backstage, and she will come on shortly to tell us about the Dance for Hope. It's an
Okay,
amazing
so without any further ado, let me just welcome. Now that you've hyped up everyone and we are all expectant, so without any further ado, let me now welcome the chairman of the Nigerian National Cancer Control Plan, the Technical Working Group, the chairman, Professor Folakemi Odedino, to grace us with our presence.
Yes, yes,
Welcome.
yes. What an amazing, amazing job you guys are doing. You are making us look not too great. The ESIs are taking over, and I am loving it. Your conversations have lit, your knowledge is on fire. I think we can all retire knowing you are taking over. Go on, take over the baton from us. Okay, so, but there is going to be another battle. I think the senior people, and I can call myself the senior, we're going to have to challenge you young ones to dancing. So I know who my partner is going to be. I'm going to dance off against Dr. Bolajoko. She does not know how to dance. So I know that I'm going to win it for the senior people when Dr. Bolajoko is dancing. But amazing, amazing. I am so glad that you all are here. We are up to something very, very important that I am just super excited about. Good evening, everyone, and welcome to NCCP Thursdays Live. I'm going to give a cue to some dancing moves later on, so I hope everyone behind the scene is going to be ready to dance, whether you're watching us, whether you're on the stage. We're going to show you how to do it. But today is a very special day because we are launching something that I believe will become one of the signature traditions of the Nigerian National Cancer Control Plan. We know that cancer treatment is more than surgery, chemotherapy, and radiation. Many patients, unfortunately, still struggle because they cannot afford transportation, accommodation, food, medication, so other just basic necessities needed to complete treatment. This is why the NCCP established the Social Determinants of Health Initiative. And I have to tell you, it's one of the strongest initiatives that we have, and I love it. And the initiative is to ensure that no Nigerian is denied cancer care because of any financial or social barriers. Tonight, this is our launch. Tonight, we are inviting everyone to join us in a fun but meaningful way. We call it Dance for Hope. This is not about dancing alone, but we still want you to dance. We want you to move. But this is about giving hope. This is about changing lives. This is about making sure that every dance becomes a donation. So I don't dance free. I want you to donate when I'm dancing, and 100% of your donation goes towards the Social Determinants of Health Initiative. Every donation becomes access to care, and every participant becomes a champion for cancer patients. So I kind of want to see how it is done. I think we can put this down right now. Dance for Hope, because I'm going to get my dance on. Do we have a DJ? Can you give us some music? Let me show people how it's done. Louder, please. Okay, I hope everybody's dancing. I'm going to show you all my moves because I want to show you on all as well. movement of my move, what you're going to see on August 12th is going to be different. I'm going to bring the game on. Okay, so now it is time to keep this movement going. You can do your dance and you can challenge anyone. So now my challenge goes to Dr. Uche to accept the NCCP Dance for Hope Challenge. Dr. Uche, are you there? Will you dance? Will you help raise funds for cancer patients? Will you help us remove barriers to cancer care? Dr. Uche, the floor is yours. And you can take me off the stage. Let's see Dr. Uche move.
Yes, my able chair. I'm here and I accept the dance and I want to show my moves. And I'm hoping that everyone will join me to make this move for cancer patients. Because every cancer patient needs hope, needs support, needs assistance to initiate and complete their care. And so I dance, and as I dance, I encourage everyone else to join me. Yes, because it's very important for us to begin to give hope to those who are downtrodden, those who non-medical barriers have inhibited from accessing care, those who can't afford to feed or to pay their transportations or to be able to have accommodation to initiate, sustain, remain, and complete their care. Can you raise the music higher, please? Thank you so very much. And we are hoping that everyone else will join as I challenge Oluwa Busayo Oguni to join me.
Hi, good evening, Dr. Uche, and good evening, Nigeria. So I don't really have a very nice dance move, but I'm dancing so as not to leave any cancer patients behind because of transportation, accommodation, or even nutrition. So I'm challenging all the technical working group chairs, co-chairs, all the integration of our cancer survivors, challenging our ESIs. I want us to dance and donate.
Watch us how we move like this. Watch us how we move. Oh, yeah. Watch us how we move like this. Watch us how we move. Oh, yeah. We gon' move like this, like this, like this.
Okay, well, wait. Busayo wants to disgrace us, right, Dr. Uche? Busayo, do you still do the job? You can't disgrace us. You cannot dance better than me and Dr. Uche. That is not going to be allowed. Okay, but let's bring our ESIs back. Let's see their move. Do the ESIs know you want to step? Or is the only book that they know? Okay, come on. You can bring the Bola to go up too. I know she can't dance, but she can do something.
Watch us how we move.
No, she can dance. I've seen her dance before.
Watch us how we move like this. Watch us how we move.
Okay, so let's lower it because we want to do it. A very call to action. Tonight, we are launching much more than a fundraiser. We are launching a movement, where every dance creates hope. Every donation changes a life. Every participant becomes an advocate for cancer patients. Beginning today, we invite every member of the NCCP Technical Working Group, every Nigerian, every Global Advisory Council member, National Advisory Council members, friends of Nigerians in the diaspora, partners, friends, families, institutions, and everyone who believes that no Nigerian should face cancer alone to accept the dance for hope and challenge. So we're going to dance for 1 more minute. I just want to see the dance move because we're going to challenge the ESI of that day. Okay, Dr. Uche, hurry up. Show them your move. Come on. More music, please. Oh, look at Dr. Iche is doing it. Yeah. Woo. Okay. Okay, I think Dr. Uche can dance. Okay, Dr. Uche, you are going to be the head of the scientist and clinician group. I can see your move. Okay, you can see Dr. Echo cannot dance, so we're going to make sure that you compete with him and you beat him up.
If he cannot dance, you have to pay someone to dance for him.
Absolutely, we choose the people who cannot dance. So I like Dr. Daniel's move, so we are not going to choose that. Okay, Dr. Lawyer, I don't know what you are doing. You're just shaking your head. Okay, Busayo, come on. Thank us. Okay, thank you so much. I am handing it over to Dr. Uche to close us out and encourage us in the best way to be able to dance for hope. Okay, over to you, Dr. Uche.
Yeah, thank you so much, everyone who has joined this dance. Remember, it is one dance, one donation for one patient, one family, one Nigeria, so we can end cancer. Who says it's not possible? It is very much possible to end cancer, because those who have been suffering are going to now receive hope through our contributions, through dancing, through donations. So thank you so much, everyone. And let the dance for hope, the challenge officially continue. Thank you so very much, everyone, for this. Thank you.
Challenge has started. Come on, bring the challenge online now. Thank you so much. God bless, and have a great evening for the rest. Okay, let the music take us out. Thank you.
Thank you.